Okay, here in part 6, this week we've broken up into two areas, the SA node, and now we're going to talk about dysrhythmias in the atria. We're going to discuss atrial tach, multifocal atrial tach, premature atrial contractions or PACs, paroxysmal supraventricular tachycardia or PSVT, or probably more commonly heard as SVT, atrial flutter, and AFib. So atrial tach, what we're looking at is something a little bit too speedy in the atria. We'll do our typical rate here and analysis for a 6-second strip. So 1, 2, 3, 4, 5, almost 6 there in that rate as far as our complexes. So usually normal. The rhythm is slightly irregular. So if we pulled out our R to R wave and we measure, a little bit irregular. Pacemaker site, it can vary among the SA node, atrial tissue, and the AV junction. So as you're looking at your complexes here, notice the difference between the P waves we see in the first 3 complexes and 4 and 5, even up to 6. A little bit different. And again, if we measure, I'd be willing to bet those R to R's are a little longer, a little different there. So the atrial tach, P waves are variable or absent, so it just depends on where its site of origin is. If you notice up here, kind of the little stars are representing different areas in the atria that are a little excitable and firing a little bit before the SA node. Again, PRI varies depending on the source of the impulse, so that interval is going to be less or a little more dependent upon where the actual atrial impulse originates. And then the QRS should be normal because we've still got conduction down into the ventricles. So variant of sinus dysrhythmia, to be honest with you, it's kind of hard to pick up. It's hard to catch it, but it can be a natural phenomenon at very young or very old. May also be caused by ischemic heart disease or atrial dilation. So it just depends. It's kind of difficult to catch that. Not necessarily any clinical significance, but maybe a precursor to other atrial dysrhythmias like AFib or A-flutter. So there's not typically any treatment. Usually a patient doesn't even feel anything or have any issues with signs or symptoms for you to look at. Multifocal atrial tach. This is when we go down our rhythm here, I'm not even going to count all those, but I can tell we're at a rapid rate for a 6-second strip there. The rate is definitely greater than 100, and then the rhythm is irregular. So again, our measurements there from R to R, we can tell they're not the same. So irregular. We've got pacemaker site being ectopic sites in the atria. So in this diagram up here, the photo, you've got multiple areas that are trying to take over the pacemaking rhythm there. So you've got some areas that are kind of irritable. Think of it as kind of lightning strikes in different places that are overriding that SA node. The P waves organized, non-sinus P waves, or at least 3 forms. So you've got multiple forms there you see on that strip. It's not anything that's consistent. So with that inconsistency, we know it's not firing from the SA node, it's not firing from the same site, and that's what the representation is there in that diagram, with 3 multiple sites being utilized to fire that automaticity. The PRI is going to vary depending on the source of the impulse, so the distance, your PRI for instance, this impulse up here in the left atria, if that's where the impulse is originating, is going to be a little longer than the one that's going to be closer to the AV junction. So that's why you're going to have a difference there. And the QRS could be variable. It just depends on what conducts down to the ventricles. So it's typically seen in acutely ill patients. May result from pulmonary disease, metabolic disorders, heart disease with ischemia, or any kind of recent surgery. The presence of multifocal atrial tach often indicates a serious underlying illness. So let's look at whatever the underlying illness is and try to work on that, and that may correct this dysrhythmia. premature atrial contractions, or PACs. This is just where we have a little difference in the atrial jump, or the kick, if you will. We're looking at our complexes here. The first three look pretty normal, pretty much the same. The fourth one, and then we get into the fifth one. We've got a quicker contraction that's been premature there before what we would have expected. So the rate's going to vary, depends on the underlying rhythm. So again, we're only looking at 6 seconds out of a full minute here, so rate's going to depend on that. The rhythm usually regular except for the PAC. So if we were taking out our calipers and measuring our R to R's all across here, the first 4 would be fine, but bam, we obviously have one that's jumped up here, and it's come up a little early. So the pacemaker site is going to be an ectopic site in the atria, someplace that's jumping a little early. It's firing, it's a little excitable, and it's firing before it's supposed to. The P waves occur earlier than expected, as we see in that fifth complex, and then the PRI varies dependent upon the focus of the impulse, or the foci of the impulse. So it just depends on where it's firing in the atria. And the QRS again is usually normal because you have the regular conduction down in the Purkinje fibers. So reason it's happening: single electrical impulse originating outside the SA node. It may result from the use of caffeine, tobacco, alcohol, sympathomimetic drugs, ischemic heart disease, hypoxia, dig toxicity, or maybe just idiopathic. It may just be something somebody has. So when you're getting your history and you're getting your information on this patient, find out if they've had any iced tea that day, or green tea, or if they're trying to lose weight and using a supplement. Find out if they're a smoker. Find out if they've had a lot of alcohol, binge drinking, or a combination of tobacco and binge drinking. Look at their medications. Are they exhibiting signs of chest pain? Find out all those things as part of your history for that patient. Typically, there's no clinical significance. Presence of PACs may be a precursor, again, to other atrial dysrhythmias, but in general, PACs from time to time are no big deal. They just may or may not happen. If you've got an asymptomatic patient that's not describing any pain or discomfort, then that may just be what they have on a regular basis. But treat a symptomatic patient with high flow O2, high concentration O2, and go ahead and establish IV access. You'd be surprised the PACs may actually clear up or go away if they can get some high flow O2. Paroxysmal supraventricular tachycardia, or SVT. Without counting those beats, I know we're definitely above 150. So our parameters are basically 150 to 250, so that's a really rapid rate. We know that goes outside of the normal at 100. We're up to the other problem with this rate is that obviously there's not enough time for good cardiac filling, and so we've got a poor cardiac output. And remember, we talked about anything over 140 beats per minute lowers the efficiency of that output. The rhythm is very regular. You notice it's very, very predictable there across the screen. Pacemaker site is the atrial. It's outside of the SA node, so there's some place that's irritable. In this diagram here, it's not coming from the SA node. It's up high somewhere, but it's overriding that pacemaker. And the way I think of it is kind of like the throttle stuck, and it's just really on high. The engine is just really revving right now. P waves are often buried in the preceding T wave, so you really can't see the P wave impulse. It's going way too fast. PRI is usually normal, and the QRS is usually normal. The big kicker here is looking at the QRS to determine its supraventricular, in other words, above the ventricles, and it's got a narrow complex. When we get into ventricular tachycardia, it'll be a wide complex, and we'll look more at that as we get down the road. But just remember, for one of those parameters we really want to focus in on this rapid rate is the narrow QRS. So problems for this, or how it comes about: rapid atrial depolarization that overrides the SA node. So like I said, think of it as an irritable site in the SA node, in the atria that overrides that SA node, the typical pacemaker site. may be precipitated by stress, overexertion, smoking, caffeine. So again, back to the tobacco, caffeine. Think about the Red Bull and the Monster and the 5-Hour Energy and taking over-the-counter weight loss pills, things like that. Those are going to be things that can contribute to the rapid metabolism, but alongside of that you have these cardiac issues. So it may be tolerated well by healthy patients for short periods. So if you've got somebody that's in relatively good shape or younger, they can go, their hearts can kind of go like a hummingbird for a while. But your older folks are typically going to have a decreased level of consciousness. They feel weak, tired, blackout, and the cardiac output is just so low that efficiency's gone down that they're just not able to sit upright. Marked reduction in cardiac output can have angina, so you may have chest pain related to this because of poor perfusion. Hypotension, you're definitely not going to be able to palpate a radial pulse or take a blood pressure, or congestive heart failure, so you could start to have fluid buildup. And remember, paroxysmal is just a fancy way of saying that it starts and stops. It's like again, like a throttle on a car that sticks on occasion, and it will start, it will speed up, and then occasionally it will slow back down. So that's the whole big word for paroxysmal. Treatment, we always want to start off with our vagal maneuvers. Try to get the patient to bear down like they're having a bowel movement. I found also some people try to get people to cough. That seems to be another method. If you can get them to cough, that might help. But vagal maneuver is a very basic thing you can start off with. If we get a chance in the lab, you can hook yourself up to the monitor and bear down and lower your heart rate just by bearing down with that vagal stimulation. Pharmacological therapy is our next step. We want to look at adenosine. You want to establish an IV with access close to the heart. That means the AC or closer. You want to have a large bore catheter. Needs to be 18 or bigger, preferably a 16 or 14 gauge. And then when we administer adenosine, for national standards, we give 3 successive doses, whichever one works. We start off with 6 milligrams, followed by 12 milligrams, and a third dose of 12 milligrams if we don't have success with the first 2. When we do administer adenosine, it's one of the different drugs because of the fact that it has a 6-second half-life, meaning that the drug metabolizes and degrades within the body within 6 seconds. We've got to push it very rapidly. So if you have 6 seconds of time to get that from the vein to the heart, or for your injection site to the heart, then you typically chase it with what we call a chaser with 20 cc's of normal saline. So oftentimes the best way to do that is have a partner with you, and once you push your 6 milligrams in for that initial dose, go ahead and push the 20 cc's behind that, crimp off the line, and force that in, and that forces that through the veins into the heart as quickly as possible to get the desired effect. Another good rule of thumb is to always have your patient on the cardiac monitor with paddles in place, just in case you have a problem or an issue. You'd be ready to charge up and fire if you had to defibrillate the patient or do something else. Verapamil is also a good tool, can be used. It just depends on the protocols that you use locally, and it is also a blocker there that would help you. Electrical therapy would be the third step. Consider if a patient is symptomatic with a heart rate of greater than 150 beats per minute. So if they're unconscious, unresponsive, severe chest pain, severe respiratory problems, then you want to consider synchronized cardioversion, which means that you push the sync button on, you cardiovert them starting at 100 joules, and we use that cardioversion to knock that irritable site out, give the pacemaker site to take back over again. So that's kind of our last resort if we can help it. I choose to try to do the best I can with pharmacological first, but on occasion you may have somebody that you may have to cardiovert. And don't forget, we want to consider giving something like Versed to sedate the patient prior to the electrical therapy. This is a tachycardia algorithm. Again, this is back to that 2005 AHA guidelines. Some of you may or may not have this in your book. You don't necessarily need to follow this. Make sure that when we get to ACLS that you follow the 2010 guidelines and make sure that we are following that. I would not use this as a template for now. So atrial flutter. The rate greater than 250 to 350, ventricular rate varies. So your conduction is really fast. So we just don't know how efficient. It's basically just fluttering, if you will. We're just not getting good cardiac compression and squeeze. The rhythm is usually regular. If you'll notice this particular strip here, even though it's not real pretty, it is regular. So look at each one of those complexes and see that we've got conduction to the ventricles. Pacemaker sites, atrial, it's again outside of the SA node. You've got some F waves that are present, just some poor, basically poor P waves, if you will, with no conduction beyond that. PRI usually normal, if you can measure that. These complexes are a little difficult to see, but if you measure that P wave in front of each QRS, you've got a normal amount there, and then the QRS is conducting to the ventricles. So, but again, at the atria, we've got a fluttering sensation that's taking place. So again, it's an inefficient thing. Doesn't push the blood around. Another little trick with this strip is if you have a strip like this that prints out on the monitor and you're trying to decide is this a flutter or a fib, it's a good idea to flip the strip over, and we call it shark tooth or picket fence. And if you'll flip it over, you'll notice the jaggedness of it, but it does have a pattern. Sometimes it's easier to do with your strip if you have a printout. So why does it happen? Results when the AV node cannot conduct all the impulses. They may be conducted in fixed or variable ratios, so it may go up and down. Usually associated with organic disease such as CHF or something of that nature where they've developed it over time. Generally well tolerated. The patient may or may not have any issues from it. Rapid ventricular rates may compromise cardiac output. So if you've got a fluttering in the atria and all of that's conducted down to the ventricles and you have RVR or rapid ventricular response, if you've got a 250 impulses that are being sent out from the atria and many of those are being captured in the ventricles, then that speeds up things, and now we're in a cardiac compromise. But if you noticed in the strip before, the atrial conduction was happening, but not all of those impulses are getting down to the ventricles because we don't have a QRS complex with each one of those pulses. So may occur in conjunction with AFib. So these two may flutter back and forth, if you will. Consider a ventricular rate is greater than 150, that we may, in other words, if that ventricular capture is greater than 150 beats, then we know that we're not doing enough cardiac filling and enough cardiac squeeze, and if they're symptomatic with chest pain, shortness of breath, or decreased LOC. So synchronized cardiovert, again, starting at 100 joules, and consider that cardioversion therapy. We may want to consider dilitazam, or verapamil, DIG, beta blockers, procainamide, and quinidine. So those are some options that we have out there. We'll certainly get into that more when we get into your ACLS. And finally, AFib. Atrial rate between 350 750, so it's really fast. The rhythm irregular. So we're definitely, if you look at all these, we only have so many ventricular captures, which are represented there again by the QRS complexes. So a lot of multiple sites that are firing up in the atria, and it's fibrillating, so it's just not doing a good job of efficient movement of blood. Pacemaker sites, the atrial, outside the SA node. The P waves are really not discernible. You just can't tell exactly what a P wave is versus where it runs into a QRS. Just not a regular thing. There's no regular PRI, and the QRS, at least in width or in duration, is normal. So you're getting capture, but again, this is a conduction problem from top to bottom. It's rapidly fibrillating up top, going down to the bottom, and then we're only getting capture ever so often here. It's just not a regular capture. This is a very irritable heart. It results from multiple ectopic foci, so in other words, multiple areas are trying to override the SA node, and they're doing a good job because they're going way too fast, and the SA node just can't keep up. So the AV conduction is random and highly variable. So this is a pretty irritable heart, often associated with underlying heart disease. Clinical significance, the atria fail to contract effectively, reducing cardiac output. It can be well tolerated as long as you have normal ventricular rates between that 60 and 100 beats roughly. But if all of those electrical impulses are being conducted and you have RVR, again, your patient's going to be decreased level of consciousness or dizzy, that type of thing. High or low ventricular rates can result in that compromise. So consider ventricular rates over 150 to be symptomatic, and think about that synchronized cardioverting starting at 100 joules again. We want to go back to that pharmacological therapy. Consider Valium, verapamil, DIG, beta blockers, procainamide, and quinidine. And then possibly an anticoagulant if there's heparin or warfarin that we're carrying. We want to be concerned about if we've got that long-term AFib, then we've got a concern for stroke or clotting that can take place just because there's not good movement through the pump or through the heart. So that's the end of that section.